was a paranodal antibody. I'm going to start off by telling a story. And the topic that was given to me will become self-evident in a while. So let me start off with a story of a real patient. So Mr. J, he's a 78-year-old male. I saw him about a year ago, last May. He has got quite a number of medical problems. He was diagnosed to have kidney disease about 10 years ago, and he was labeled as glomerulonephritis, but for some reason, there was no biopsy done, and he was put on dialysis because he progressed on to end-stage kidney disease. He also had hypertension and gout, as well as some ischemic heart disease that was stable. 10 years ago, he had cancer of the large bowel that was treated. And in the last few years, he's been noted to have low blood counts, which the hematologist evaluated and thought to be due to myelodysplastic syndrome. Okay. Recently, his chest X-ray and CT thorax showed some areas of consolidation, which remained stable and did not show evidence of an infective or neoplastic process, but this was still under evaluation. So this is the background of the patient, which may or may not be relevant, but it certainly colored the way we evaluated the patient later. So he came to us through another hospital, through a private hospital. The history that he gave the doctors who saw him in the private hospital was that he had an infectious prodrome, upper respiratory tract infection. 1 week after that, he was driving, and fairly acutely within a period of an hour, he developed left upper limb weakness and numbness without any pain. Okay? So the clinical examination at that time could be summarized in the same way that I've been discussing with many of your trainees. So I would like to, because I'm aware that there are many trainees in the audience. So I would like to go back to the same so-called formula that we always use. So even though it was just focal weakness, his signs were consistent with lower motor neuron disease because it was flaccid lower limb weakness with reduced reflexes, and there was no evidence of upper motor neuron disease. The weakness was predominantly proximal rather than distal and was associated with sensory loss. So by this formula that many of you also use, the managing doctors thought it was something to do with this part of the equation. So what are the diseases in this part of the equation? Well, because it's confined to one limb and not affecting the lower limbs or the right upper limb, lower motor neuron deficits, proximal weakness with sensory loss in the upper limb alone can either be a proximal radiculopathy like C5, C6 radiculopathy or a plexopathy. Okay? So with that, a person went ahead with some evaluation at the private hospital. A cervical spine MRI was unremarkable. MRI of the brachial plexus was also unremarkable. The neurologist concerned went ahead with an electrodiagnostic test, and this was the summary that was given to us. Essentially, it was unremarkable. Now, with this story, even though there was no pain, the doctors thought, and I think correctly, that this is most likely an acute inflammatory brachial plexopathy, possibly induced by the viral infection prior to the onset 1 week ago. But unfortunately, he continued to progress with starting to develop symptoms on the other side of the body, as well as in the lower limbs. And the left upper limb became very severely weak and numb. At this point, the doctors gave him a course of immunoglobulin. But in spite of that, over the next 2 weeks, he started developing increasing weakness. He started developing shortness of breath. He couldn't swallow. And he developed flaccid weakness in other parts of the body. Okay? But still predominantly over the left upper limb, followed by the left lower limb. Okay? So, at this point, just to make sure that everybody is on the same page, what do you think is the possible diagnosis? Remember, this patient was taking medications for gout, and we know that patients with kidney failure and who are taking excessive amounts of gout can develop an acute paralysis of all four limbs due to acute rhabdomyolysis that often looks exactly like Guillain-Barré syndrome. But the key feature is often a very rise CK and the absence of sensory findings. So these were the various differential diagnoses we had. And going back to the formula again, just to prove to you that if we are systematic, we are likely to get it right. Again, when we examine this patient, this time he's with us now, he came to our hospital. His findings on all four limbs were suggestive of lower motor neuron pathology. The weakness was predominantly proximal. There was clearly sensory loss, but unlike at the beginning, now he had involvement of all four limbs. So therefore, the only diagnosis that is common for such a constellation of clinical findings would be acutely Guillain-Barré syndrome and chronically CIDP. So we agree with the majority of you, and we thought this patient's diagnosis is most likely Guillain-Barré syndrome. So we went ahead to do the relevant investigation. This was the spinal tap. This is almost about 2 weeks into his illness. And this was the spinal tap, which was essentially unremarkable. And the nerve conduction study, this time we managed to trace the previous studies. We closely looked at them and looked at the previous studies. And the only remarkable finding we thought was the relative sparing of the sural nerve compared to the involvement of the median and ulnar nerve in the upper limbs, and a mild reduction in compound muscle action potentials in all the nerves that we studied. So we still thought this is consistent with an axonal form of Guillain-Barré syndrome, and we continued to treat him as per Guillain-Barré syndrome. But over the next 4 weeks, he continued to progress. He became completely paralyzed in the left upper limb. His right upper limb also became severely weak, and both lower limbs were weak to the point where he couldn't move anymore. And although he didn't need respiratory support, it was quite clear that he had some respiratory muscle weakness. And during this period, he was given feeding through a Rouse tube, a nasogastric tube. So we decided to repeat another course of IVIG because of the progression. And this was last year when we still had no data about second IVIG. And we repeated the nerve conduction studies. Again, the most remarkable feature was a reduction in the compound muscle action potential, some mild hints of slowing in certain areas, remarkably at the areas of entrapment sites. Okay? And again, a relative sparing of the sural nerve compared to the median and ulnar nerve. So, at this point, we were getting very nervous because the patient was getting weaker, and we didn't really have a specific diagnosis. So we went back and thought about the various possibilities. So could this still be Guillain-Barré syndrome? Could this be acute onset CIDP? Remember, he had a chest X-ray finding that suggested consolidation. So we were thinking about sarcoidosis. Remember, he's got 2 neoplasms, one in the bone marrow, which resulted in myelodysplastic syndrome. And 10 years ago, he had cancer of the bowel. So therefore, a malignant infiltration causing polyradiculitis was also important. And remarkably, although I didn't put it in the slide, at this point, he also started complaining of hearing loss, left ear hearing loss. So besides involvement of the lower cranial nerve, he had involvement of the left ear, which made us think that this must be an infiltrative process. So let's go through these various diagnoses. Now, as you know, Guillain-Barré syndrome does not progress beyond 4 weeks. But this patient was clearly in front of our eyes, getting weaker by the day. So we were quite confident that this is not Guillain-Barré syndrome. Now, the point, then we started thinking, okay, we know that there's a subgroup of patients with CIDP who can develop the weakness so acutely that in the first setting, it looks like GBS, but the chronicity tells us it's CIDP. So this is what we call acute onset CIDP. But the point against this, when I was discussing with my residents, is that I couldn't be convinced of any demyelination in the nerve conduction studies. The demyelination was very subtle, especially compared to the amount of weakness he has. Okay? Remember, weakness in demyelination usually translates to severe conduction blocks or severe temporal dispersion, both not seen. So this was inconsistent with acute onset CIDP at that stage. Then we started thinking about sarcoidosis and did some workup because of the lung changes. But again, all the non-invasive workup for sarcoidosis did not reveal a diagnosis. So then finally, we thought it may be a malignancy. So as you know, spinal tap, for finding cancer cells, the yield is low unless you send large volumes. Because in most laboratories, by the time you send 6 bottles for the various tests, the amount that finally goes to the cancer, to the pathologist, is so little that the yield is often very poor in standard spinal taps. So when you're suspicious, you must always repeat the spinal tap and send all the CSF. Don't waste it on any other test. Every CSF that you have, you should send it for cytology or flow cytometry. Okay? And if necessary, there are some studies that suggest that the third spinal tap increases yield significantly. So with that in back of mind, we went ahead and did large volume spinal tap. We did also some genetic markers or markers of lymphoma in the CSF, and none of them suggested a neoplastic process. Nevertheless, we went ahead with a bone marrow and a PET scan, and they were all normal. A repeat nerve conduction study again showed similar changes as the earlier studies, with no conduction block, no signs of demyelination, but, sorry, I take that back. Small signs, small subtle hints of demyelination, but again at entrapment sites only. Okay, so with that, we started thinking, what else could it be? Could it still be acute onset CIDP? So at this point, well, we thought possibly could this be the topic of today's talk, which is paranodal CIDP. So at this point, we sent off the antibodies, the relevant antibodies, to the relevant laboratories and found out that he had a very high titer of IgG4 against CNT1 antigen. So what is paranodal CIDP? Okay, with the limited time that's given, okay, what I've done is given you a very nice summary. Okay, I haven't given the summary. Well, I've actually copied for you a nice summary that Dr. Ogata has done. And this is a free access article, so it's easily available everywhere. So please scan this QR code and you can download this very short, succinct article that will summarize what paranodal CIDP is. Now, as the name implies, the pathology involves antigens, as I have marked in this picture, antigens that are found not in the node, but in the paranodal area. Okay, and the paranode is an important part of your myelin sheath, which is responsible for preparing your node to make the saltatory conduction. The analogy I always use is that if you watch Formula One racing, for the race cars to make this loop around the circuit very fast, they need a very powerful, very sophisticated, very well organized pit stop. Okay, with all the mechanics to change your tires, put in your petrol, make sure everything is ready so that you can make this loop without breaking down halfway through your circuit. So the same way, the paranode has got all these mechanics running around, changing your tires, putting petrol, doing all kinds of things to prepare your node for this big jump. And the jump is the electrical conduction from one node to the next node. It's like going around the circuit. So when that fails, then the patient's nerves cannot conduct. And when they can't conduct, there's conduction failure. And because the conduction failure causes weakness, with not much slowing, it looks like axonal process. But because it involves the node, which is primarily your apparatus for myelin-mediated conduction, there's hints of slowing. So paranodal disease is characterized by physiology, electrophysiology, that has features of axonal disease, but also some hints of demyelination. So if we are tuned into it, you will start recognizing it. Okay, so that's the physiology behind paranodal disease. So let me go through some of the key features of this subtype of paranodal CIDP, the one that's associated with anti-CNT1 antibody, and you realize that it's very similar to our patient. First and foremost, this is not a common disorder. So over the years when we have seen CIDP, this is probably less than half a dozen patients that we have over a period of 20 years maybe. Okay, so it's not common. Okay, and it presents very acutely. Remember, this man was driving and he noticed weakness within an hour. So almost like a stroke, so acute. So that's why it's often called acute onset. It's whenever you see acute onset CIDP, you have to start thinking about CNT1 antibodies. Okay, it's predominantly motor, as this man manifested severe weakness with very little sensory abnormalities, both electrically as well as clinically. Now, changes of axonal and demyelinating pathology in your electrophysiology. And what else? Yes, many of these patients have kidney disease. Now, remember, I mentioned to you, this is a man 10 years ago was diagnosed by the renal doctors to have glomerulonephritis, but unfortunately, they didn't do any workup for him, and he went on to end-stage renal failure. So we wonder whether his kidney disease is also immunological, and perhaps at that point, he may have responded to immunological therapy if the right antibodies were done. Okay? Now, this group of antibodies are very special because they are not IgG1 or 2, but IgG4. Being IgG4, they are not complement mediated. And maybe that explains why they are often not responsive to IVIG. This patient received 2 courses, didn't respond at all. And often steroids don't respond also. So in this patient, actually at the 3rd or 4th week, we did also add on quite a bit of steroids, high-dose steroids. And again, he was not responsive to steroids. But as this paper nicely explains, these patients are very responsive to rituximab. So this patient now has come back to normal function. Can you imagine? He was bedridden. 1 year later, now he's driving his car again, playing golf, okay, with repeated causes of rituximab. So tremendous response with rituximab. Now, the other type of paranodal antibody is antibodies associated with neurofascin antigen. Okay, this is slightly more common than contactin CIDP, slightly more common, but nevertheless still rare. And the phenotype is slightly different. The patients are younger. They often don't present with acute onset. They present like standard CIDP. They often have demyelination on their nerve conduction studies, but very predominantly distal. Okay, and like many other distal CIDP patients, they often have a lot of sensory complaints, ataxia, and tremors. And like contacting patients, they don't respond very well to IVIG, but there is some suggestion they may respond to plasma exchange better than, so you should consider plasma exchange for these patients. And likewise for contactin also. I think in places where rituximab is not affordable, I think plasma exchange is a good broad spectrum treatment that you can consider for either type. Now, the other interesting thing about neurofascin antibody is that these patients often have symptomatic or asymptomatic central nervous system demyelination. Now, the basis of this has been debated. There's still some controversy whether this is a real phenomenon, but this is something to look out for. So if you see somebody who looks like CIDP in the peripheral nervous system, but has MRI changes suggestive of multiple sclerosis, then again start thinking about this particular disease. Okay? So, what are the lessons this case taught me? Number one, CIDP associated with paranodal antibodies can present acutely like GBS. So when you see an acute onset CIDP, think about paranodal antibody. And even if it shows mainly axonal features, Okay, my thinking always was acute onset CIDP should only be in a so-called AIDP-like picture, patients with demyelination. But this case taught me that even if it's a Aman-like picture, acute onset CIDP should be considered, especially associated with contactin antibody. Okay? And then, just to prove to you how the nerve conduction studies can be quite tricky, what I've done is superimpose the images, the waveforms for you. The one on the left is the one that we did when the patient came to us, then the following test, and then this is the last one. You can see that the distal latencies of the median nerve is slightly prolonged, but he's a 78-year-old man with end-stage renal failure, so easily dismissed as carpal tunnel syndrome. His compound muscle action potentials during this period when he's progressively weakening is not showing actually that much drop. It's 5.3, 6.7, 5.7. So this suggests the must be blocked even distal to the point where we are, even proximal to the point where we are stimulating, right? So that's why the patient's CMAP is still intact in spite of the fact that the patient is very weak. And you can see on the far right-hand corner, the conduction velocities are quite robustly normal, right? Close to 50 meters per second. Likewise, in ulnar nerve, there is a hint of slowing at the distal point and at the entrapment side. So again, the Guillain-Barré syndrome studies have taught us that neuroimmunology is maximum, neuropathology in immunological disorders is maximum at sites where the blood-nerve barriers are disrupted, and they are most disrupted at entrapment sites as well as the distal nerve segments. So not surprisingly, there are some hints of slowing in the patient, in this patient at the entrapment site and at the distal point, again dismissed as coincidental entrapment, but actually it may be part of the pathology. But otherwise, the most remarkable feature about this patient's nerve conduction study is the reduction in the compound muscle action potential of an axonal disease. Likewise for tibial nerve, so I won't waste your time with it, but just to show you that F waves, the impersistence of F waves, in spite of the robust CMAP, explains what I just mentioned earlier. The fact that the patient must have a very proximal block. Because otherwise, how else do you explain? You can see quite clearly the impersistent F waves tells you that most of the pathology here must be very proximal, and therefore these patients are weak, even though the CMAPs distally are relatively intact. And of course, my final point of sural sparing. So here, I've illustrated the median nerve, ulnar nerve sensory potentials on the top and the sensory potentials of the sural nerve at the bottom. You can quite clearly see that compared to median ulnar nerve, sural nerve remains even later in the disease relatively robust. So we personally believe, okay, although we have not been able to convince a lot of people, that this sural sparing should be included as a diagnostic feature of all forms of GBS and perhaps also in demyelinating or non-demyelinating forms of CIDP. Okay? And that's why we proposed some time ago a modification of your diagnostic criteria for GBS based on sural sparing as a cornerstone of the diagnosis. Not an afterthought, not an additional luxurious thing, but a cornerstone of diagnosis. As you can see below, we put sural sparing as the most important component, and then think about other motor abnormalities to make it, to grade it either as possible, probable, or definite GBS. Okay, so in summary, I've described to you an unusual subtype of CIDP. Unusual, but important to recognize because they respond to treatment, but also not to standard treatment, but to slightly different treatment like plasma exchange or rituximab. And the two common types among these rare forms of CIDP are the ones associated with contactin and neurofascin. And you can kind of suspect or smell their diagnosis from the clinical phenotype. So contactin tends to be predominantly motor, presents often acutely, okay, in older patients, and responds very well to rituximab or plasma exchange, but not so much to IVIG. While neurofascin presents in younger patients, okay, has more demyelinating than axonal features, more consistent with the CIDP phenotype, and often don't respond well to IVIG, and the patients are often disturbed not so much by weakness, but sensory loss and ataxia as well as tremor. So, and then sometimes don't be surprised if the imaging of their spine or the brain shows some demyelinations in this patient. So with that, I will stop for questions. Thank you very much for the attention, and thanks again for inviting me.